Good morning, good afternoon, and good evening to everyone. My name is Haris Boglu, and I'm part of the American Club's business development team. And I would like to welcome you all to the American Club's loss prevention webinar. As you already know, this webinar will be about COVID-19. Now, before we get started, I would like to go through a few small housekeeping items, which you can also see on the share screen. To begin with, please note that the microphones and cameras will be disabled during the course of this webinar. However, please feel free to use Zoom's Q&A feature right at the bottom of your screen in order to type in any question you may have throughout the presentation. Please note that the copy of this webinar's presentations, along with its accompanying materials, will be sent out to participants as part of a follow-up email, along with a brief questionnaire. Meanwhile, please note that today's webinar is being recorded and will be made available on the club's YouTube channel. However, please allow us 1 to 2 business days for the webinar recording to be posted. Now, I would like to thank you all for your attention. And without any further ado, I would like to introduce you, your moderator for today's webinar, Ms. Elena Souley. Elena Souley is a Business Development Director and FT&D Claims Manager for the region of the EMEA, Europe, Middle East, and Africa for Shipowner's Claims Bureau Alas Inc., the Piraeus Claims Liaison Office of the American P&I Club. Elena, over to you now.
Thank you, Haris, and let me welcome you as well to our today's webinar, which is related to the COVID-19 implications. And we are going to approach them today both from a medical perspective as well as a claims and loss prevention perspective. The global COVID-19 pandemic has indeed resulted in a number of big challenges for the maritime industry. And we have all no doubtly sought ways to adjust our operations to the new reality. At the American Club, we were very quick in adjusting to the new virtual working environment in order to maintain a high level of service to our members and develop further our knowledge sharing initiatives, aiming to add more value and assist the industry to deal with a unique situation triggered by the outbreak of COVID-19. Within that context, we have prepared this webinar for you together with other webinars. We have a series of webinars, and we hope that you will all feel that these are enlightening for you. So let me introduce to you the speakers for today, our esteemed speakers, starting with Dr. Arthur Diskin, who currently is a Global Medical Director of Future Care Inc., and he will give us the medical approach. Our Joanna Kukuli, who is our Senior Vice President, Deputy Claims Director, and Joint Managing Director at the Office of SEBLS in Piraeus, Greece. But most importantly, within today's context, is also participating on behalf of the American Club to the IG Working Group for the COVID-19 issues. And at last, our Dr. William Moore, who is Senior Vice President and Global Head of Loss Prevention at SEB office in New York. So with that, so let me pass on the floor to Dr. Diskin to give us his perspective. Dr. Diskin, please.
Good morning. It's my pleasure to go ahead and give this presentation. I'm going to try to give as much as an update, current update as I can on the status of the COVID virus. So what I would like to do is go ahead and start my presentation here. So a little bit about my background before we start. I'm currently the Global Medical Director for Future Care, which is a company that provides case management services to ship owners for their crew, both while they're at sea and should they have to be disembarked in port or repatriated to their home countries. And as well as we're doing a lot of work with arranging for COVID testing and handling other issues related to the COVID pandemic. My background includes 8 years as the Global Chief Medical Officer for Royal Caribbean Cruise Lines, where I was responsible for the medical care of 50,000 crew members, medical operations on our 40 ships, and anything related to public health issues. Usually I was dealing with norovirus and Legionella and a little bit of Ebola, but we had our share of different types of outbreaks, but certainly nothing like we've seen with COVID. Prior to that, for many years, I was the medical director for Carnival Cruise Lines, which was more of a consulting advisory role. And my basic background is critical care and emergency medicine. And I've been the head of several emergency departments in the South Florida area. I'm currently on the teaching faculty of the local university hospital down here, Jackson Memorial Hospital. And I also have a company, Quality Medical Risk Management, that provides risk and claims management to a medical malpractice insurance company where we insure approximately 1,000 emergency physicians. So I have some background in the risk management area as well. So as of November 1st, we're looking at about 46 million cases worldwide. Today's the 11th, so we're significantly higher than that. It's really been estimated that we probably have 10 times as many people actually infected. So we probably have somewhere around 500 million people who've actually been infected by the virus worldwide. The deaths are now over 1.2 million people. And out of these, pretty consistently, as we go along, the US has had about 20% of the cases and 20% of the deaths. Now, one thing that it has to be taken into consideration, because it really affects everybody's mindset as to what action should or should not be taken against this virus, as is balanced against the country's economy and the effect not only on the pure economy, but the effect on the remainder of access to healthcare and issues such as the secondary effects of not having kids in school for a prolonged period of time. So as the case fatality rate decreases, we wonder whether or not we're going to see an increase in tolerance to the presence of the virus on a global political basis. So why is this occurring? One is more testing is being done. Two is that we really have better isolation of at-risk individuals and vulnerable populations. So we really are protecting our elderly and protecting more vulnerable members of the population, or they have a better understanding of the virus and are self-isolating for a longer period of time and are aware of what they have to do to decrease their risk. We have a decrease in super spreader events, and these super spreader events tend to involve younger people more than older people, things like bars and weddings, indoor restaurants. So we continue to have these, I guess, with the exception of some of our political events here in the US. We've decreased the intubation and ventilator use and used other methods of managing hypoxia or low oxygen concentrations. So in the beginning, everybody got intubated. And once you're intubated, your mortality rate became very high. And as we stopped doing that, we started to see a decrease in mortality rates. And we have better recognition and treatment of the complications, because this is not just a respiratory virus. People have problems with their heart. People have neurological problems. They have problems with clotting, vascular problems as well. And we have the availability of medications at the appropriate stage of the illness, because we always have to remember that it's a two-phase illness, that you get the viral infection and then you get the body's response to it. So we have things such as antivirals, anti-inflammatories such as dexamethasone, plasma from people who've had the illness. And now we're seeing the rolling out of monoclonal antibodies against the virus, which are very effective, especially post-exposure or early in the illness. And then we always have to take a look at the demographics in that in certain areas, if the population in that area is older, the mortality rate's going to be older. And if the population is concentrated in some lower socioeconomic areas or areas where there are higher concentrations of diabetes or hypertension, other comorbidities, then you're going to see a higher mortality rate. And the one thing that needs to be considered a lot more is long-term morbidity. And we'll talk a little bit more about that later. But just because you get sick doesn't mean if you get well that you really get well. And a lot of people are having a considerable number of long-term medical problems post-infection. So what are the challenges to this specific virus? It's very easily transmissible by droplet, which means within 6 feet or so, and that's where we came up with that. And then you have the questionable impact of aerosolized transmission, and this within the medical community, the World Health Organization, among some of the other issues they got wrong early on, is that there really is some degree of aerosolized transmission. It's not what we would think about for something like measles, where if there's one person in the room with measles, everybody who hasn't had a vaccine within about 30 feet is going to get exposed and contracted because it takes very little viral load and it's easily aerosolized. But certainly there's a continuum between droplet transmission and aerosolized transmission within a given physical space. Their survival on surfaces has been very controversial. Initially, it was thought that that would be a major source of transmission, but it really hasn't been documented to any significant numbers. And certainly from our perspective, there's never been any documentation of transmission from cargo. And when the virus, just because the virus can sit on a surface doesn't mean that it's viable and doesn't mean that there's adequate numbers to infect someone. It's easy to kill with hand washing and 70% alcohol hand sanitizers. Very easy to kill on surfaces. I personally prefer chlorine-based products. We have to understand the difference between cleaning and sanitation, that in order to sanitize something well, it has to be cleaned first. We have an incubation period that's very important, and it's generally about 5 days. So you can see sort of a standard deviation type of mathematical curve with a peak of transmission of 5 days and sort of spreading out from there, rarely less than 3 before somebody becomes symptomatic. And pretty much 97% of people have exhibited symptoms by 11 days, which means we've been always looking at a 14-day quarantine period. We may turn out to see that reduced in many circumstances to 10 or 11 days. Asymptomatic transmission with the highest viral load just before and after symptoms occur in those who do get symptoms has been a major problem, and a major source of spread of this virus is that people are spreading it when they don't even know they're sick, which is why the use of face masks is so effective to decrease spread. Not so much because the mask protects you from others, but because it protects others from you if you happen to be asymptomatic and ill and spreading virus at the time. We have this unexplained rapid deterioration for certain patients at 10 days. It's sort of the secondary hyper immune response, and we don't really have an ability to predict who that's going to happen to. We have an ability to predict that once it happens to people with significant comorbidities, that the mortality rate is higher, but we don't really know. We can't, out of a room of 10 people, sit there and with certainty predict who will develop the secondary response. And as I mentioned, the pathophysiology of this virus, especially in critically ill patients, is extremely complex. And then we have many issues regarding immunity, and everybody talks about the antibody disappearing. But to most viruses, we should have what we call underlying T cell and B cell immunity. And my guess is that we'll ultimately see people immune to the virus, despite what their antibody levels show, for probably a 1 to 2 year period. So what are the challenges for the ship owner? Number one is, if possible, keep the virus completely off the ship, especially those that have not experienced any illness whatsoever. Be able to effectively screen the crew prior to boarding. Temperature screening is only minimally effective in doing so. It really takes testing. Proper cleaning and sanitation during and between voyages, and understanding the difference between the two. Maintaining social distancing on board and preventing asymptomatic transmission, and then proper use and establishment of culture for hand washing and face masks. You need to be able to manage your contractors, vendors, and governmental authorities. I just reviewed a case from a ship in Asia where I'm pretty sure that the virus was brought on board the ship, not from crew because they had no shore leave, but from either a local contractor, vendor, or some government official. A selection of proper testing strategies, a safe management of cargo and supplies, which I mentioned. It looks like there's very little to no reporting of transmission from cargo. So probably wearing gloves when the cargo is boarding the ship is adequate? How do you manage your sick crew members? And how do you manage critically ill crew members and emergency disembarkation if ports do not want to take them? And then how do you access medical care or repatriate crew with conditions totally unrelated to COVID when, again, the local ports are reticent to accept them? Now, a little bit about the virus. The virus has this mucopolysaccharide coat with the gray area in its schematic. And that is this viral coat is what alcohol and hand washing, but alcohol certainly can kill. That's why norovirus on ships is such a major problem, is that's an unencapsulated virus. And then you have these spike proteins. And these spike proteins are important because this is what the testing is geared towards, the antigen testing, especially the more rapid antigen testing. The original antigen testing that was more complex and is still out there, such as Abbott Abbott now has both nuclear testing of nuclear antigens, which means this surface envelope needs to be broken down first, which requires reagent. And they were running into situations in which there was shortage of reagent. Now, the newer, more rapid tests, which are a little less sensitive, are to these spike proteins. But these spike proteins are also what all of the monoclonal antibody therapies are directed towards and what the ultimate vaccines are directed towards. Now, there are a number of different technologies. The two major technologies for the vaccine is something called messenger RNA technology, where you deliver messenger RNA that codes for these antigens into the body. And that gets put into your DNA and your cells, essentially, a little oversimplification. And then you're constantly making spike proteins. So you maintain a sustained antibody response to those as long as the messenger RNA is making the protein. And then you get attenuated adenovirus delivery. This is where they actually take a dead adenovirus and they deliver the spike protein with the adenovirus so that you make an immune response to it. And then a company called Vaxart is looking at orally delivered vaccine, which certainly from a delivery standpoint would be very beneficial because these all of these vaccines so far that look like they're effective are going to require extreme cold for storage and delivery. So they're all going to be very difficult to deliver and maintain at the right temperature. And they're all going to require 2 injections about 30 days apart. So as far as the testing, we have 3 groups of testing. We have PCR or molecular testing, which is the one where they have been taking the swab and putting it way into the back of the throat. And now they're looking at collecting nasal swabs or sputum. This requires some sort of a central lab. It has to be an approved lab. The false positives are very unusual if the collection is proper. False negatives really depend upon where you are in the illness process, but you can certainly have some false negatives. The biggest problem here has been the turnaround time for results, which has been upwards in some places a week. And anything really over 48 hours is not that useful. Then the antigen testing, as I discussed, is equal to nuclear or surface antigens. The surface is faster with a little less sensitivity, so there are more false negatives. It can be sputum or swab. It requires some sort of a reader. The nuclear one requires reagent, and then reagent shortages have been a worldwide problem to try to keep up with the need for testing. They're usually less costly per test, and they have much faster turnaround. And then you have the immunoassays that look for the IgG and IgM antibodies, whether you have active illness or whether you've had a prior illness. So what's next? And I think this is important. What's next is to develop frequent, low-cost, faster turnaround tests that are less sensitive, whereby you accept this less sensitivity because what you're really looking for is the degree of contagiousness of the virus. And the other thing that you're looking for is this use of pooled specimens. On a very simplistic basis, it would be if you have 20 crew members, they would all spit in the same cup. Not exactly, but you would collect sputum from everybody, put it together, and you would do one test. And as long as that was negative, it was negative. In college campuses in the US, they're testing the sewage effluent to test basically for all of the students' bowel movements in the building. They test for it once a day. If everything's negative, the building's negative. If it's positive, they start testing by floors. and then eventually start testing by student to locate any positives that might be there. So this pooled specimens may be something that we see. And of course, what we need to really look at in all of this is as these tests develop, and almost anything I present is almost immediately obsolete, but what is the role in crew screening and back to work post-infection decision makings? And one of the things that has occurred is that because the virus can testing the molecular PCR can remain positive for so long when the patient is no longer infectious. A lot of recommendations that are coming out now are empiric to just let somebody who's asymptomatic back to work after a certain period of time without even testing them. So just to give you an idea of what's out there without really promoting any particular test, there, as an example, there's something called COVID Nudge came out, very fully automated. You get a swab, you're able to put it into directly into with a swab into the machine, and then you get the result of a test from a cartridge. So you just need a very small machine at the site of testing. The challenges are access to that equipment. How do you get it? Sometimes with these tests, the governments actually sequester them for their own needs, whether it be military, schools, nursing homes. How are you actually going to use the test in your clinical decision making? What are the costs involved? And again, what is the equity of access? So one of the way where we probably will eventually see us go, maybe 6 months, maybe a year, maybe 3 months, is some sort of very low cost with a very rapid result of 15 minutes. And you can do this at home or at mass gatherings. You'll collect saliva or a nasal swab in a solution, and then you'll just put essentially a paper antigen strip in, or it'll be something like a home pregnancy test. And these will be mass produced, and you'll every third day, maybe every day, depending upon the location, maybe something like every day in a nursing home, every third day in a business. Everybody will test their saliva and determine whether it's negative or positive. And this sensitivity is enough to detect the majority of COVID virus. And again, it can also be done perhaps in a spooled specimen. So what do you lose by these lower sensitivity tests? You have a window in here where the lower sensitivity, the higher sensitivity test, like a PCR, will be positive, and the lower sensitivity test will be negative. You also, on the other end, get these, you still have this virus RNA copy, so the high sensitivity continues to test positive long after the person is no longer contagious. So there's some benefit to testing with these lower sensitivity tests on the way out as well. Now, the one point I wanted to make that I think is very important for everything that we do is that you'll remember from your geometry courses that you have this asymptotic curve that never actually crosses the axis. It gets closer and closer. And that's what we have with the risk. The risk of communicability, the risk of getting the virus will never reach zero. It's just that everything that we do, whether it's simple things like wearing a mask and social distancing, or whether it's complex things like vaccine or antibodies, we'll never get our risk to zero. And as we get here closer to the line, the investment, the dollar investment, the logistical difficulties become greater and greater. So the idea is to institute as many easy things as we possibly can and at least get us closer to that curve. So what are suggestions for ship owners? Obviously, general hygiene for crew pre-deployment. There should always be one person on board with a higher level of medical certificate. So if you have 20 people in your company, don't put all 20 of those people on one ship, distribute them evenly throughout your entire fleet. There needs to be a universal use of face masks on board until a cohort of crew is together for 10 days without illness. And then social distancing to remember that during meals and other non-work activities, while still maintaining enough social interaction for mental health issues. Hand sanitizers already, perhaps gloves while moving cargo, but not much else because we really haven't shown any risk. Tremendous education on how to put these masks and gloves on and off. Strategic planning. So every ship should really have an idea of their next several ports on their itinerary. What would happen if somebody became ill with COVID? What would happen if we needed testing? What would happen if somebody needed to be disembarked? And I think on small ships, it's probably logistically best from the viral standpoint to have a full crew turnover whenever possible. You have to be able to have a plan to manage your guests on board the ship. You have to have a plan for cleaning between voyages and disembark staterooms. Every ship should have an identified isolation cabin. And you have to understand the difference between isolation and quarantine. Quarantine really is from a word that means 40. And because they used to isolate ships would come into Dubrovnik in Venice. That's where they started all of this. And they'd make the ship sort of sit there, or they'd have an area in the port where people would isolate for 40 days so they wouldn't spread the plague or any other illness to the port. The same thing. Isolation is what we do to somebody who we believe is sick. Quarantine is something we do to people who are contacts. The increased par level for PPE. And then if you have individuals within your company that are over 60 or immunocompromised or underlying medical problems, something called Syndrome X, do you really want to put them back out on the ships during this particular time? And if you do, perhaps you want to put them on voyages that are closer to shore, or really educate them on being even more isolated while on board. I think that it's critical in this time period that flu vaccination be mandatory. There'll be nothing worse than an individual having both flu and COVID at the same time, which is certainly possible. We may look at ways of cohorting exposed and recovered crew, perhaps putting them all on the same ship. They're all well. They're all going to stay well for probably at least 6 months to a year. We can also use those individuals if somebody from the ship has to go into port for any reason. And then we need to continually update the status of every port visit. As said, we need to make sure of the integrity and accuracy of the pre-boarding testing program. There's nothing worse than somebody testing negative and then 24 hours later they go to Hong Kong or a port, and as they enter the country they test positive. And then you have to maintain a very close working relationship with your telemedicine provider. So I'm often asked, how do we manage suspected crew illness? Well, the only thing you can really do is manage them on a case-by-case basis with a close working relationship with your telemedicine provider. But the time to manage a suspected crew illness is before you have the crew illness. And what I mean by that is, again, making sure you have universal flu vaccine so you have a lower level of overall respiratory illness on board. Increase your PPEs, your isolation, location, and strategy. We talked about isolation versus quarantine. Identify previously ill crew members who can have interaction with a suspected case. Make sure you have a designated medical provider. Know what you're going to do in ports. Know how you're going to arrange testing, and then be able to categorize your sick crew so they can be managed medically based upon their shortness of breath, pulse oximetry, which you should have on board, and pulse rate. So education and training becomes critical. In the interest of time, I'm not going to go through all this, but this is just a simple, don't make mistakes regarding your masks. Right? There's a very simple things like don't allow masks with a valve because it defeats the purpose. How to use, how to wear the mask, etc. Vaccine development, just to give you a little update, there's a number of trials going on worldwide. There are about 6 major ones that have been assisted to be funded by the US government. There are 3 phases to the trial, to any trials. One is a small group to make sure there are no major side effects. 2 tests for efficacy in a small group. And 3 is a major test with thousands and thousands of people. So the questions that we have is, we now have at least 2 that are well into phase 3, and Pfizer announced over a 90% effectiveness, which is amazing. Anything over 75% is pretty much needed to ultimately get herd immunity. So that was a great, and you saw the stock market effects from that. But intramuscular versus oral, what is the antigen selection and whether or not the antigen selected will mutate? What is the time frame to see this? Realistically, I think we'll see starting in the first quarter, and we'll talk about who in a moment. Who will be accessed and prioritized? So who will get it first? So while we may see some people getting the vaccine in the first quarter, we may see the entire populations not have access till the 3rd or 4th quarter of 2021. And it also depends upon how many people will take it. That's why some people are talking about the pandemic not really becoming under total control until 2022, maybe as late as 2024. So what are the vaccine equivalents till we get it? Again, social distancing, very frequent testing with quarantine and contact tracing, and these monoclonal antibodies given early in the illness. So who will probably get it worse? The U.S. proposal is 5 tiers. And the first tier is healthcare workers, and the second is the highest risk individuals. But the third risk is essential workers. And this is where I think that the maritime industry in each of its locations must get to the point of getting their workers considered to be essential workers. So you move up this food chain. And then with mental, I want to move into quickly, and I know I'm running a little short on time, but mental health issues, because I think this is such a critical issue for the industry. Now, the major thing we look at is what are the stressors to our crew? Well, the major stressor is number one is isolation, being away from their families with this prolonged contact, prolonged lack of contact with their family, multiple extended stays, travel restrictions to get home, even if they can get off the ship. They can't even get home to mourn relatives who've died from COVID or anything else, elderly parents, whatever it may be. Limited shore leave, the financial stressors, and then just the onboard stressors of being together with a simple group, with the same group for a long period of time. And this leads to development of sleep disturbances, boredom, low job satisfaction, and we have communication issues both on board and with the company. And then all of this can be considered to be something none of us like, and that is uncertainty. And that uncertainty leads to a huge amount of stress. So this isolation issue is the key issue, and this fear of being isolated from family and support systems. Now, you have cultural and language barriers may prevent the crew from actually expressing themselves and getting the help they need. And this is critically important to any programs that are developed, is that they be culturally specific and address the native language of the crew. So these certain cultures lead to a very high threshold in certain crew members, and this is a barrier to early identification, even by the officers. And the officers should never be thought to be immune from problems of their own, which we'll see. But it increases suicide risk. It must be managed proactively at both the ship and the corporate level with very proactive interventions and not really wait for this. But in addition to suicide and mental health issues, the crew may become more prone to mistakes and accidents, putting the ship and the remainder of the crew at risk. It's a pervasive issue. It's felt that maybe up to 20% of current crew members at sea may have contemplated suicide at one time or another. And it's probably higher now, but maybe over 400,000 crew may be beyond their current contract, original contract limits. And then the officers may be as severely affected as the general crew, which then limits their potential to assist other crew members. The other problem we may have is what we may be seeing is not really mental illness amongst people who have no propensity towards it, but we have to take a look and see if we're having exacerbation in at-risk crew members. Do they have underlying mental health issues, including anxiety, depression, alcohol, and substance abuse? Why did they go to sea in the first place? Was it really just money, or were they escaping some issues at home because of their underlying mental health issues? We used to see this all the time in the cruise industry. And what can we do for this exacerbation to mitigate onboard stress issues, sleep, sunlight, diet, and then really understanding the management of culturally specific issues and making sure that they can access medical care and get their chronic medications as well. And then you have somatization, and this is we're seeing a lot from a future care standpoint, is that this is the experience and communication of psychological stress as somatic symptoms. So psychiatric conditions, anxiety, depression, doesn't need to be a major psychiatric problem, but they generate physical symptoms. And this is one of the leading causes of crew returning home when they return home, finally seeking medical care. So it's led to us have very complex case management issues, because first we have to work up, evaluate, and make sure that there's nothing physical actually going on for complaints such as chest pain, headache, back pain, etc. And then we have to go ahead and get them the medical resources to address the somatization aspect of their illness with things such as cognitive behavioral therapy. So the secondary medical expense that we're experiencing is a little harder to measure, but it's an additional metric. Suicide prevention is the most tangible metric to measure for any mental health program because it's very finite. The numbers are there, but the numbers are usually very low. So any change in those numbers creates a false sense of effectiveness. Whereas if we can measure the utilization of medical resources in general and specific to some of these issues, we can see much greater benefits of interventional mental health programs. So you need a designated mental health officer on board the ship, very culturally sensitive support programs via video, telephonic, or online. There's certainly a number of YouTube videos that the crew can be directed towards. And mental health assistance through your medical case management assistance companies. We certainly have developed a program at Future Care. And then there's specific training programs, such as ISWAN has one for crew that can be accessed. And then looking at corporations as ways of increasing social interaction and connectivity amongst the crew in the age of COVID without necessarily exposing them to close contact while on board the ship and diminishing the social distancing. And one thing that certainly should be addressed on board all these ships is the general crew wellness programs of sleep, exercise, hydration, diet, and making sure their own medications are available. So with that, I'll finish. I apologize if I went a little bit over, a lot of information, but certainly if anybody has any questions, I am available now and later.
Thank you, Dr. Diskin. I see already that we have one question, but I think we will take it up later at the end in case somebody else also comes up with another question for you. So I think now I will just pass on the floor to our Joanna Kukuli, who will also share her experience from the handling of various COVID-related claims amongst the club's membership, but also very importantly will share with us her experience from her participation within the IG COVID-19 working group. So Joanna, please, the floor is yours.
Thank you, Alina. Good afternoon to everyone and good evening to our audience from Asia. Indeed, it has been a very rewarding experience for me to represent the American Club in the international group's COVID-19 working group. Now, for some background, the working group was formed back in March in order to address the abundance of issues that were recurring as a result of the unprecedented situation generated by the COVID-19 outbreak. As issues were raised across the international group standard subcommittees, the ad hoc working group was formed to discuss the aspects of P&I affairs affected by the COVID pandemic on a centralized basis, in order to avoid duplications and overlaps between the other subcommittees. For me, as the American Club's representative, together with my peers from the other 12 IG groups, the working group has been a dynamic forum for sharing and discussing the various COVID-related issues that arise day to day in claims handling. Since March, we have come a long way. We started from streamlining the IG's launch of a publicly accessible COVID-19 digital tracking tool to assist ship owners, charterers, operators, and other parties in the maritime sector to track country and port-specific advice around the world and detail the measures being put in place in response to the COVID-19 pandemic. The tool sources data from all 13 international group clubs, the IMO, the World Health Organization, and other leading sources, including Wilhelmsen and GAC. So this is a single user-friendly source, making the most up-to-date and pertinent information on COVID-19 measures applicable in different jurisdictions, readily available and accessible, and allows parties to identify commercial risks and physical threats worldwide. In the more recent months, it has been particularly helpful for ship owners in dealing with crew changes, and has had more than 400,000 hits since its inception. Of course, the American Club, in collaboration with colleagues in the group, continues to participate in updating this extremely useful tool that can be found on the international group's website. Now, from a claims perspective, the working group has been a vigorous virtual roundtable for troubleshooting on various queries relating to the operation of P&I cover. The members were raising as they were facing and continue to face new challenges due to the global outbreak. This facilitated the creation of a pool of scenarios which most, if not all, IG clubs drew from in order to formulate frequently asked questions, therefore highlighting the most commonly encountered issues and how club cover would respond thereto. Indeed, the American Club's COVID-19 quick reference guide located in our website, as my colleague Dr. Moore will further elaborate, comprehensively addresses practical problems the members have been facing amidst the pandemic vis-a-vis always P&I insurance cover. So in a nutshell, COVID-19 is covered under the club's rules in the same way as any other crew illness. The fact that COVID-19 spread worldwide, qualifying as a pandemic, does not render it any different to other types of illnesses for club cover purposes, since there is no pandemic exclusion per se. Now, a question that often arises is whether P&I cover applies to the period during which crew members travel to and from vessels. If COVID-19 is contracted by a member while traveling from his or her home country to the vessel or from the vessel back to his or home country, the member's liability and expenses arising under the applicable law of the employment contract may be recoverable from the club. So the point of reference is the employment contract's governing legal regime, which will determine the ship owners as an employer liability. Now, turning to diversion, as with any illness requiring the vessel to divert in order to arrange for medical treatment ashore, such expenses would fall under club rules, and more specifically, Class 1, Rule 2, Section 12. Cover is limited to those additional costs listed specifically in the rule, i.e. bunkers, insurance, stores, and provisions, and only to the extent that the additional costs represent a net loss to the member over and above the costs that would have ordinarily been incurred absent the diversion. It goes without saying that if a crew member is to be disembarked, members should check with their local agent and club correspondent in advance to ensure that they are able to obtain the necessary medical assistance and are allowed to discharge any ill crew member or passenger, for that matter, at the port to which it is intended to divert. Now, if a crew member has been disembarked for medical reasons, whether or not connected to COVID-19, but the medical repatriation is delayed due to general COVID-19 travel restrictions, the resulting expenses would be covered as part of the crew member's medical repatriation, so long as it flows from the covered risk. Actually, this is a more commonly encountered issue compared to COVID-19 illness cases per se. Indeed, it is COVID's general overspill effect that is predominantly causing difficulties in day-to-day handling of cases, also, although they're not substantively COVID cases. It is important for this to be distinguished from routine crew repatriations when a crew member's contract of employment has expired, but he or she is prevented from being repatriated as a result of general travel restrictions due to COVID-19 in the country of disembarkation or the home country destination, respectively. In such instances, the crew member may be required to stay at a hotel or other facility for a certain period for self-isolation in accordance with local restrictions. And the question arises as to whether the club will reimburse the associated expenses incurred by the member. The answer is that any such costs would be operational and would not be covered, as cover under the club's rules would not be triggered absent an outbreak of COVID-19 on board the vessel. On the same premise, when a crew member must remain on board for a period after his or her contract has expired due to disembarkation restrictions preventing routine repatriation, again, associated expenses would be operational and not covered under the P&I policy. However, one must bear in mind that P&I cover could respond to the owner's liability and expenses arising under the employment contracts applicable law in the event of a crew member's illness, including COVID-19, or injury or death during the intervening period until he or she is actually repatriated. Now, a lot has been said about quarantine and what club's rules cover when triggered as a result of a COVID outbreak on board, which is a requirement according to our rule, namely Rule 2, Section 11. Thanks to the plethora of loss prevention initiatives and consistent protective measures which ship owners have adopted and crew have faithfully observed on board vessels during the past months, vessel quarantine cases are now quite scarce. What we have seen, however, to be on the rise are cases of crew members becoming infected during their transit prior to joining the vessel or after disembarking in the course of their repatriation trip. And as previously mentioned, P&I cover would respond to a member's liability and expenses arising under the employment contracts applicable law for a crew member's illness, including, of course, a COVID-19 infection. The COVID-19 pandemic has given rise to unprecedented challenges for ship owners due to local quarantine measures, travel restrictions, and border closures, preventing crew members from traveling to and from vessels. International organizations, including the International Group of P&I Clubs, have made efforts for seafarers' special status as key workers to be recognized, so as to allow necessary crew changes and repatriations globally to be carried out without inordinate delays. Organizations such as the ILO have issued notes and guidelines for shipowner employers who have, from our experience, managed to adjust their operations to the challenging circumstances with the assistance of their respective flag administrations and governments, which had to adopt a pragmatic approach due to imperative reasons of public health vis-a-vis the extension of employment contracts, the adjustment of minimum safe manning, and the extension of medical certification. Ship owners and managers literally try to go the extra mile to carry out necessary crew changes wherever possible. However, this must be done within the parameters of the governing contract of carriage. Otherwise, there is a risk for the deviation to be deemed unreasonable and deprive the owner of the right to rely on defenses and limitations of liability, which would have otherwise been available, and in turn, this could potentially prejudice P&I cover. Although global travel restrictions are beginning to relax, in many countries, those which remain in place continue to hinder crew changes. In response to this crisis, BIMCO recently produced a new clause, quoted here for your ease of reference, designed to give owners the liberty to deviate if crew changes cannot be effected at the places to which the ship is ordered to call by charters. The clause also provides an option for charters to contribute to the crew change in recognition of the potentially high cost of making COVID-19 related arrangements of this kind. Of course, it all boils down to the negotiation dynamics between charters and owners, which will, of course, determine the incorporation or not of such a clause in the charter party to begin with, or which version will be agreed upon. And as pointed out in the clause's explanatory notes, it is important to remember that such clause does not automatically guarantee P&I cover. Therefore, before exercising such liberty, as with any envisaged deviation, it is imperative that members notify the club in advance in order for us to carry out the necessary evaluation as to whether cover would remain in place. As of late September 2020, it is estimated that approximately 400,000 seafarers remain on board commercial vessels, unable to be repatriated and past the expiry of their contracts, which means that a similar number of seafarers urgently need to join ships to replace them. As pointed out by Dr. Diskin, crew changes are vital to prevent psychological fatigue and protect seafarers' health, safety, and well-being, ensuring the safe operation of maritime trade. Unfortunately, it continues to be the burning issue almost a whole year after COVID-19's outbreak. Hopefully, in the next few months to come, as medical advancements and innovation are breaking through, more countries and ports will be added to the list where crew changes are permitted. And when we next meet, this will hopefully be a problem of the past. Thank you very much.
Thank you very much, Joanna. That was indeed very enlightening for all of us. There's more question for you, but I think I will also keep that for the end. Before, I would like to pass on the floor to Dr. Moore, who will elaborate on the loss prevention initiative, and most importantly, of the COVID-19 guidance that has been prepared by the club. So Bill, the floor is yours. Thank you. I think you are muted.
Unmuted,
Okay.
yes. Now I'm
Great.
unmuted. Thanks.
Thank you.
Thank you, both Dr. Diskin and Joanna. So excellent presentations thus far. Nicely leading into me for my finish here. Just want to put this picture up. Is that there's a lot of different things going on still with COVID-19. We began starting to accumulate our guidance from a P&I perspective on the matter back in March. I remember the first inquiry coming in, asking if there was, one ship owner asking if there was guidance they could provide as they were entering Wuhan, of all places. And ever since then, it has been quite an interesting path that we've taken, and all the different things that we've looked at from all the different perspectives from a P&I point of view. Just as an overview, as mentioned briefly by Joanna, that the American Club, we maintain a dedicated section on our website to a reference page on COVID-19. It covers a wide range of different subjects and interests related to COVID-19. There are things on the medical side. There are charter party and contract guidance that we had developed. As also mentioned by Joanna, our COVID-19 quick reference guide. I strongly recommend that everyone takes a good look at that. It answers some quickly answers some very direct questions on FAQs that are very specific, primarily related to claims, is the most of the emphasis from the COVID-19 quick reference guide. We also periodically issue circulars and alerts as they become available. We normally do not talk about everything that's going on in every single port and all the changes that are going on there as a result of COVID-19. However, if there is something significant, like we just put out some recent guidance on one of our alerts related to crew changes in China, because that's quite significant, because it also included both international as well as domestic crew. We put out guidance such as that, but we keep a very detailed set of guidance, industry links to ICS, Intertanko, and alike. We've also put out other guidance on bunkering under COVID-19 conditions. But as I've also mentioned briefly a moment ago, if you have not had an opportunity to look at the Williamson COVID-19 port restrictions map, it's a very good resource. It's generally pretty well updated. It's updated at least twice a day, but it's a very good resource for different information that you may need for the COVID-19 outbreak and port restrictions and any requirements that may be additional to the norm. But as I mentioned, we are continually adding more and more information to our website. To our COVID dedicated reference site. And please feel free to also contact us directly if there's anything, as mentioned just a few moments ago by Joanna, as it relates to charter parties, but also anything on the loss prevention side. If we don't directly have it, we will help you find it. So please do so. Just a brief mention in the end, just all of the loss prevention materials. We have been quite adamant through the years that all of our loss prevention materials on any subject are all available on our website. And I also, as relate, for some of you, I'm sure who are listening in today, members have been excellent about sharing information on the pre-employment medical exam program, PME compliance, issues with seafarers who are still on board. We have been extending about every 6 weeks. We've been extending when a seafarer actually his PME expires, okay, both his medical certificate as required under SDCW 19, that's another matter, but our PME requirements, we have been extending those for seafarers on board. And we about every 6 weeks, we put in a new alert or new circular stating that we'll extend it as much. But for new seafarers coming in, please be advised, for anybody who's going on board a ship, we still will need to make sure that they're complying with the club's program. We go out of our way to assist members. I've been getting periodic requests for, well, how do I deal with this clinic and this, or these clinics in this location? Philippines, as difficult as it has been generally okay to get seafarers PMEs done. India has been a bit more of a challenge. Eastern Europe has been generally okay. India seems to be our only real challenge that we've seen thus far. Although Philippines can be challenging, we still seem to be able to get the PMEs done there. But everything that we do on the COVID, all the things we do on the loss prevention can be found at our website. So I will conclude with this picture here. We wish you all free pratique on all your vessels. And thank you very much. And I turn it back to Alina. Thank you, Lynn.
Thank you, Bill. Thanks to all the speakers for the very extremely informative presentations. We already have under the Q&A session a couple of questions which I would like to address to the respective speakers. So Dr. Deskin, starting from you, there's a question stating that with regard to the lower sensitivity testing, do you feel that we currently know enough about the period of contagiousness to potentially risk losing catching cases at the beginning and end of the curve?
Sorry, Art, you're muted.
I'm sorry. In order to get tests turnaround quickly and useful, there's the possibility that we sacrifice some degree of sensitivity in this, and we substitute that by doing the tests more frequently so that we don't miss anything at the beginning, or that we miss fewer cases. Again, it's always a matter, you're never going to get that curve all the way to zero, so how low do you want to get it? And the math works out pretty well for every third day, and then again, in certain high-risk situations, perhaps every day. And you do lose a little bit, but not that much compared to what you lose by having to wait 48 hours for molecular testing to come back. At the back end, it is actually somewhat of an advantage, because with most of our current testing, we're picking up people who are positive, but actually are not at all contagious anymore. So a little less sensitivity will actually help us if we're going to use the testing at the back end. In general, for most people, the idea is if the fever is gone for 10 days and the cough is either absent or minimal, they're feeling relatively well, that 10 days is a good period of time for most people to go back to work. Those who've been hospitalized for their illness their back to work should probably be determined along with their medical physicians at that point, maybe a little bit longer than the 10 days if they've been very sick in the hospital. But I think that the availability of the testing to be done quickly and at low cost overcomes all other challenges.
Okay, thank you. That was very detailed. And I'll go to Joanna now. There is a question for you, Joanna. If a crew member is diagnosed while on board and then goes home and infects his or her family, would the family costs be covered? You are muted.
Thank you, Alina. Sorry.
You're fine.
Obviously it's we can't generalize answers. Okay, each case is judged on its own merits in PNI. The answer would basically depend on the legal regime that governs the contract of employment of the seafarer, which would determine exactly the ship owner employer's liabilities towards their employee. So it would very much depend on the circumstances and facts and legal background of each individual case. So it wouldn't be safe to give a blanket answer on that. Thank you.
Yeah, that's fair. Thank you, Joanna. And Dr. Denskin, if I may also raise a question for you. You touched on briefly on the mental health in your presentation, which we all appreciate how important it is. Can you tell us a little bit more about your thoughts on this, as it's a critical issue, especially during this pandemic era?
I think that it's some of the subtleties that become very important to recognize. And I think one of them is that our crew come from a variety of different cultures and locations. And I think we have to be willing to have our programs be tailored to the needs of those particular cultures. We need to be able to do that as far as recognition of the mental health issues. We need to have programs that are gender specific. We need to have programs that are nationality specific, age specific. I think you were speaking a little bit about PMEs. I certainly think that the inability to recognize pre-existing and existing subtle mental health issues on PME exams is certainly a very big challenge to the industry and is something that has never really been totally addressed as far as identifying crew members who might have issues, especially now in the current environment going out to sea. So certainly a greater degree of awareness. There are programs being instituted. I think it's great, but we need to be aware of the fact that all crew members are not necessarily created equal, and one program does not fit all.
Thank you very much indeed. I think knowledge sharing would, amongst all market players, would assist in building awareness in this instance.
Yes.
And Joanna, I'm sorry.
Can I just
Go
make
ahead.
one small comment based upon what Dr. Diskin just said? We have, as it relates to PMEs, we have struggled mightily through the years from our PME program that's been in place since 2004 with regard to psychological testing. And we basically just last year removed the psychological test from our PME exam for the only reason is that it wasn't capturing information. We're looking for other ways to be able to capture, let's say, to see if there's a mental issue with a particular crewman. Been talking to a lot of the manning agents about that from time to time, about do they ever catch things, just in general conversations they have with someone when they're spending 8 hours with them, or 4 or 5 hours with them when they're interviewing them. And I do get some interesting comments back from them, but we've tried to put out more information in our loss prevention functions on mental health with a mental health site that we actually a reference site as well as a couple mental health guides. But yeah, it's an issue we struggle with. So I'm sorry, I just want to make that point based upon Dr. Diskin's points about PMEs.
No, very, very valid point. Thank you, Bill. Thank you, Bill. So I don't see any other question on the Q&A session, but I would like to extend a final question to Joanna based on her experience so far from dealing with COVID-19 related claims. Have you seen any specific trend that you think we can share with the membership that are of particular interest? Thank you.
Thank you, Elena. As I mentioned during my presentation, we have seen a rise of COVID-19 cases whereby seafarers are contracting the virus during their transit period. So we don't see so often, and almost never, I would say, as far as our club is concerned, always, quarantine cases due to an outbreak on board the vessel. Thankfully, these are very, very rare by now, but we do see a spike in the transit period contraction of the virus. So it's either prior to the seafarer joining the vessel or during his repatriation trip back to his home country, which is on the rise. And as now the virus is spiking again, I'm afraid that we will see more of them going forward. Thank you.
Yeah. Thank you. Thank you very much. And I see we don't have any other questions on the Q&A. So on that front, I think we can now bring the webinar to a close. Thanks very much for all of you for attending, and especially thanks to our speakers for enlightening us on the issues regarding the ever-evolving challenges on the COVID-19 pandemic. So on behalf of Shipowners Claim Bureau and the American Club, we wish you good health and stay safe during these difficult times. And before we close, just keep in mind that all the presentation from today's webinar will be sent to you together with relevant documentations, and we will also send you an email with an invitation to complete a short questionnaire in order to get your feedback as to how we can assist you further on this front and any other